Here's the 6-part playbook we're going to sprint through today. 1. Renal trauma and repair. 2. Tuberculosis of the kidney. 3. Pyelonephritis and abscesses. 4. Benign cysts and tumors. 5. Renal cell carcinoma. And 6. Wilms tumor in children.
Section 1. Renal trauma and repair. Managing external forces. So, the absolute first question for suspected renal trauma is simply this: are they hemodynamically stable or unstable? Stable patients get a contrast-enhanced CT. Unstable patients, you bypass the CT entirely for a single-shot intravenous urogram.
Now, we classify this trauma across 5 grades, and there is a massive clinical shift that happens right at grade 4. So grades 1 through 3 involve minor hematomas and simple lacerations without a urine leak. For these, we generally manage conservatively. But grade 4? That's where things get intense. This grade introduces either a vascular injury or urinary extravasation, basically a urine leak that can form a urinoma. If that urinoma is sterile, we place a double J stent. But if it's infected, we go with an ultrasound-guided pigtail catheter. Any vascular injuries here require surgical vessel repair with Prolene sutures. And finally, grade 5 is a totally shattered kidney. Honestly, this often leaves us with no choice but a partial or total nephrectomy, assuming, of course, the other kidney is functioning normally.
Now, this brings us to one of the most fascinating and, frankly, frequently tested complications of renal trauma. It's called meteorism. Imagine a retroperitoneal hematoma slowly expanding. Somewhere between 48 to 72 hours post-injury, that hematoma starts putting immense physical pressure on the splanchnic nerves. And the result of that? A massive colonic distension. It is such a striking visual anchor, and it really reminds us just how tightly interconnected our anatomical compartments actually are.
Of course, trauma isn't always from accidents. Sometimes it happens right there in the operating room. Ureteric injuries actually pop up quite a bit during difficult pelvic surgeries, like hysterectomies, when you're clamping ligaments or vessels. If you spot the injury during the surgery, we have a very precise 3-step surgical protocol. For a partial tear, you just repair it with absorbable sutures. Simple enough. If it's a complete transection, but the ends are still close together, we anastomose them over a DJ stent. But if there's a significant loss of a segment, well, that's where we have to get creative to bridge the gap. We might use the appendix, a bladder flap, which we call a Biari flap, or as a total last resort, we join it to the other ureter.
Section 2. Tuberculosis of the kidney. Hematogenous invaders.
When TB spreads through the bloodstream, it initially sets up shop by forming a papillary ulcer, and then it just wreaks absolute havoc on the urinary tract. The clinical terminology for this is incredibly vivid. For instance, if that initial TB ulcer undergoes caseous necrosis, the entire kidney can actually fill up with pus. We call that a putty kidney. If that putty then calcifies, it becomes a cement kidney. In both of these scenarios, the kidney is entirely non-functioning and requires a nephrectomy. As the infection tracks down further, it physically forces the ureteric opening to stay wide open, creating what's known as a golf hole orifice. This is bad news because it allows urine to reflux right back up. And finally, as ulcers inside the bladder start to heal with intense fibrosis, the bladder shrinks drastically. This leaves the patient with a severely reduced capacity thimble bladder.
Section 3. Pyelonephritis and abscesses, the upper tract infections. We see these very frequently in females during puberty and pregnancy, where catching it early is absolutely critical.
So, let's rapidly compare 2 severe, highly specific variations of pyelonephritis that you absolutely have to lock in. First up is emphysematous pyelonephritis. This is caused by E. coli, and it creates literal gas inside and around the kidney. It's incredibly dangerous, especially for diabetic and immunocompromised patients, and it very often leads to a nephrectomy if antibiotics don't work fast. In stark contrast, we have xanthogranulomatous pyelonephritis. This one is caused by Proteus, and it classically presents in middle-aged diabetic females. On a CT scan, it forms a low-density mass that looks remarkably like a bear's paw. You'll also see those massive staghorn calculi that are a dead giveaway for Proteus infections.
Section 4. Benign cysts and tumors, classifying renal growths. Now, as we transition into cellular mutations, there's a vital rule you need to know. We generally do not biopsy these. We rely almost entirely on CT scans.
And the way we make those non-invasive diagnoses is by using a strict clinical roadmap called the Bosniak classification. It goes like this. A Bosniak 1 or 2 is just a simple cyst. 0 cancer risk, absolutely no follow-up needed. A score 2F means follow-up is required with regular CT scans because there's about a 5% cancer risk. But the crucial tipping point is score 3. This is an indeterminate lesion. We legitimately cannot tell if it's benign or malignant from the scan. And with a roughly 50% risk of cancer, the standard management moves straight to a partial nephrectomy. A score 4? That is clearly malignant and requires immediate surgical removal.
Before we rush ahead, let's pause for a second to define a highly dramatic clinical presentation that's tied to a very specific benign tumor, the angiomyolipoma. So this tumor is essentially a mix of blood vessels, muscle, and fat, and occasionally it just spontaneously ruptures. When it does, it causes Wunderlich syndrome. This is a massive retroperitoneal hemorrhage presenting with something called Lenck's triad. The patient will suddenly develop a palpable flank mass, severe pain, and severe hypotension or shock. But notice what's missing there. There is absolutely no hematuria. The bleeding is entirely contained back in the retroperitoneal space.
Now, while many of these benign tumors are completely sporadic, you have got to lock in their connections to some crucial genetic syndromes. Angiomyolipomas are famously linked to tuberous sclerosis, which also presents with ash leaf macules and seizures. Then we have Birt-Hogg-Dubé syndrome on chromosome 17. This syndrome is linked to oncocytomas, which happen to be the most common benign kidney tumor, and they feature a really classic central stellate scar on a CT. Birt-Hogg-Dubé is also linked to chromophobe renal cell carcinomas. Interestingly enough, radiologists often really struggle to differentiate a benign oncytoma from a malignant chromophobe RCC because they can both have that stellate scar, which if you're tracking, lands them straight into that Bosniak score 3 indeterminate category we just talked about.
Section 5. Renal cell carcinoma, the malignant threat. RCC is famously dubbed the internist's tumor because it presents in so many bizarre, systemic ways that patients usually end up seeing an internist way before they ever see a surgeon.
Let's systematically break down the 4 pathological types of RCC. Clear cell is by far the most common. It arises from the proximal tubules and is strongly linked to von Hippel-Lindau syndrome. Next is papillary RCC, which is uniquely associated with patients who are undergoing long-term dialysis, and it features plasmama bodies. Then there's chromophobic RCC. This one has these strange plant-like cells with raisin-like nuclei. Sounds weird, but fortunately it carries the best prognosis of the group. Conversely, collecting duct RCC, which has a deletion of 1q, carries the absolute worst prognosis. And a quick note here, its medullary variant is specifically tied to sickle cell anemia.
So, I mentioned earlier that RCC is the internist tumor, right? Well, this next point brilliantly illustrates why. RCC can actually manipulate the body's chemistry far away from the kidney by secreting various compounds. One of the most heavily tested paraneoplastic syndromes here is Stauffer syndrome. It causes severe hepatic dysfunction. We're talking elevated liver enzymes and bilirubin, but here's the catch. Not a single cancer cell has metastasized to the liver. The liver is simply reacting to the tumor's chemical signals, specifically IL-6. And the crazy part? Once you surgically remove the kidney tumor, the liver magically returns to normal. When it comes to treating RCC, burn the number 7 in your memory, specifically 7 centimeters. This is the critical size cutoff for a T1 stage tumor. As long as the tumor is under 7 centimeters and remains confined entirely to the kidney, a nephron-sparing partial nephrectomy is our go-to surgical option. And that's crucial because remember, RCC is notoriously chemo and radio-resistant. Surgery is absolutely our main weapon here.
But as the tumor grows, the staging shifts dramatically, and it's all based on exact anatomical boundaries. A stage 3 RCC is very aggressive. It might creep right into the major renal veins or even the inferior vena cava, but it remains contained within a tough connective tissue boundary known as Gerota's fascia. But the exact moment that tumor breaks completely through Gerota's fascia, or if it directly invades the adrenal gland on that same side, we instantly shift to a stage T4. This is a highly dangerous staging that dictates a massive.
Section 6. Wilms tumor in children. Pediatric malignancies. This is the most common pediatric renal malignancy, and it typically strikes children right between the ages of 2 and 5.
When a toddler presents with an abdominal mass, the radiologist essentially has to pit Wilms tumor head-to-head against another very common childhood mass, the neuroblastoma. So how do they tell them apart? Well, Wilms tumor generally features peripheral calcification and, critically, it rarely ever crosses the anatomical midline of the abdomen. Neuroblastoma, on the other hand, features calcification right there inside the tumor itself, and it frequently crosses the midline. And again, just like earlier, we don't biopsy these. We rely entirely on these exact CT findings to make the call.
Now, what's really fascinating about managing a Wilms tumor is that unlike RCC, Wilms tumors are actually highly sensitive to chemotherapy and radiotherapy. However, there are two fiercely competing international philosophies on exactly how to use them. The National Wilms Tumor Staging Group advocates for doing the surgery first to get the tumor out and then following up with chemotherapy. Meanwhile, the Society of International Pediatric Oncology believes in giving chemotherapy first to shrink the tumor down and then going in for surgery. It perfectly demonstrates the deep, ongoing complexity of pediatric oncology.
So after all the imaging, the staging, and the surgical debates, what really decides this child's fate? What specific microscopic detail viewed by the pathologist ultimately dictates the true prognosis of a Wilms tumor?
It all comes down to the cells. The proportion of blastemal components determines the prognosis. The higher the blastemal presence under that microscope, the worse the expected outcome.